Mental capacity, put simply, is the ability of a person to make a decision. We all make thousands of decisions every day, some big, some small. Often we will need help, support and information to make these decisions. Occasionally, we may not be able to make a decision for ourselves despite this help because of something that is affecting our mind or brain at the time. At Leeds Teaching Hospitals Trust, we see about 1 million patients a year and are committed to making sure that our patients remain at the heart of decision-making about their care and treatment, whenever and however they can. The Mental Capacity Act 2005 is the law that governs how we support all of our patients who are 16 or over to make informed choices about their healthcare. It also tells us how we must respond when there is a doubt about a patient's capacity to make a decision for themselves, and what we must do to demonstrate that decisions we make on behalf of adult patients who lack capacity to make specific decisions are made in their best interests. Every healthcare worker who has contact with adult patients must, by law, be able to show that their practice is in line with the Act and its guidance. In this film, we will take you through some of the key provisions of the Act so that you can apply them in your practice. It is important also to remember that you need to demonstrate you are following the Act. So you will also need to be thinking about how you record your practice. The Act is underpinned by 5 key principles. These are at the heart of everything in the Act and are the basic legal principles that all of us must be able to show we are putting into practice as we work with all patients aged 16 or over. If we are confident that we are following these principles and can demonstrate we are using them, we can be sure that we are protecting the rights of our patients while giving ourselves legal protection too.
Anyone over the age of 16 has already in law the right and the ability to make whatever decisions they may face, whether they're small decisions, easy decisions or complex decisions. And for us that means that we have to envisage that every adult patient who comes to the Trust already comes with that right to make the decisions about their health care. So it's sort of saying, rather than thinking negatively about people's abilities, start with an open mind, start by assuming that even if they need some extra help or support, they still basically have that ability and that right to make decisions. Even if we have doubts about someone's abilities, which we may well do for all sorts of reasons, our first job really is to try and maximise their own ability to make decisions. So it really says that you can't treat someone as unable to make a decision until you've done whatever's practical and reasonable to help them make that decision themselves. So that might be about making sure we've given them the basic information that they need to make a decision, so the risks, benefits, just that basic set of things. And we've given them that information in the best way possible for them. So if someone is struggling with short-term memory problems, the onus is on us to try and repeat that information, do it in a creative way that's best for them to think through those issues and understand it. Just because someone makes what might seem to you or other people as an unwise decision, that in itself is no indicator that they lack capacity to make that decision. So in other words, we're all allowed to make those risky, unhealthy, unwise, eccentric decisions. It's very easy, I think, if someone, for example, is refusing treatment, it's very easy for us to start making assumptions based on that unwise decision. We start making decisions or judgments about their ability because they're refusing what we think they ought to accept. And the law's just kind of saying, hold on a minute, let's unpick the reasons why they're making these decisions. And sometimes that might lead us to a judgment that they do indeed lack capacity to make that decision, but often It's simply that they have a different perspective, a different set of values, different lifestyle choices, and they're just making a decision that, whilst we would recommend they don't take, they still retain that capacity and that right to make that unwise decision. If someone can't decide for themselves on any matter, any treatment decision or care decision, then we have to act in their best interests. Now, on the face of it, that seems fairly obvious. If you asked any clinician, they would often say, well, I always act in the best interests of my patients. But actually, best interest is a little bit more subtle than what most people would imagine. So, for example, one of the things I often say is that doing something that you think is best for a patient, so produces the best clinical outcome, isn't necessarily in their best interests. So best interest is about clinical effectiveness, good outcomes clinically, the best kind of treatment, but also a much more sort of person-centred approach to that. So it's considering that clinical information as well as things about their lifestyle, their wishes, their beliefs, their values, the sorts of decisions they've made that are similar in the past. And it's taking all that information about the person and their circumstances and making a balanced judgment about which way that tips. If you've got someone who lacks capacity, so you're making decisions on their behalf in their best interest, there may still be some options open to you. There may be a variety of treatments or therapies or actions that you can take. And all it's really saying is that you need to be able to show that the option that you're taking is either the least restrictive option, in other words, least restrictive of that person's sort of rights, freedoms, or at least that you've considered less restrictive options. So actually what it says is you must show you've considered those other options, even if you don't think those other options are the best available to you. You should still at least be able to show that you've considered them and why you've rejected them. It's really legally kind of saying, because this person can't consent to what you're about to do, then you should probably look at whether you can do less to them rather than more. It still needs to be effective, it still needs to protect them from harm, still needs to be in their best interest, but it needs to be as least restrictive as possible of their rights and freedoms.
First, you must be sure you have done what you can to explain the basic relevant information to a patient. Information about the treatment, the basic risks and benefits, and the foreseeable consequences of deciding either way. Then, if you still have doubts about a person's capacity to make a decision, for example, to consent or refuse specific care or treatment, you must apply and record an assessment of their mental capacity, using the two-stage assessment. Stage 1 is the person suffering from an impairment or disturbance in the functioning of mind or brain, whether temporary or permanent, at the time they face the decision. Simply put, this is about asking yourself, what evidence do I have that there is something affecting the way the patient is thinking? This could include things such as dementia, delirium, mental ill health, reduced conscious level, significant learning disability, the effects of drugs or alcohol, or infections such as UTI. The next step is to assess whether or not the impairment and/or disturbance of mind is actually sufficient to stop them from doing one or more of the following. Stage 2. 1. Understand the basic relevant information for the decision. 2. Remember this information long enough to make the decision. 3. Weigh up and use the information as part of their decision. 4. communicate their decision by any means.
We support patients to make their own decisions by utilising different members of the multidisciplinary team. It could be that you would have a speech and language therapist would come along and help explain things to the patients. It may be in the way that the terminology that we use, we take out all the medical jargon and speak in very simple ways. We might use picture charts if the patient can understand better in that way, or it's their way of communicating back with us, because they may understand us but be unable to communicate with us. But it's about giving that time and making those adjustments for those patients in everything that we do with the patients that may lack capacity.
Mental capacity assessment should always be about a specific decision at a specific time. In other words, you should never generalise about a person's mental capacity. The record you make of your assessment should show that you have used the two-stage test and give your reasons and evidence for believing that the person is unable to do one or more of the elements of the test. You are required to show that it is more likely than not that the person is unable to understand, retain, weigh up the basic information, or communicate their decision. This standard of evidence is often called the civil burden of proof or the balance of probabilities. When a patient lacks the capacity to decide about treatment, then we have to show that we are acting in their best interests. Best interests is best thought of as a balancing act. We must show that we have weighed in the balance not just the clinical information, but also all of the following. Avoid making assumptions about someone's best interests merely on the basis of the person's age, appearance, condition or behaviour. Consider a person's own wishes, feelings, beliefs and values, and any written statements made by the person when they had capacity. Take account of the views of family and informal carers. Take account of other legal decision makers, power of attorney, advance decisions to refuse treatment, court-appointed deputy. Can the decision be put off until the person regains capacity? Involve the person in the decision-making process. Demonstrate that you have carefully assessed any conflicting evidence or views. Provide clear, objective reasons as to why you are acting in the person's best interests. Take account of the views of any independent mental capacity advocate. Consider less restrictive alternatives or interventions.
I'm just coming to bob a cannula in you because you need... What for? You just need some drugs to go through it. Well, you need some antibiotics because you're not very well at the moment.
Oh no, I don't want anything.
But you need these antibiotics
No,
because they're going to make you much better.
No, I don't want any. I don't need any.
Why don't you want
I don't want any. I don't need any.
Okay, alright, I'll come back and are you alright?
So in this first scenario we have a patient who clearly lacks the capacity to make the decision, so that judgment's been made and she needs a cannula, but in the nurse's analysis that cannulation wasn't so urgent that it required us to intervene and use restraints. What she did fairly sensibly was to try and engage the patient about it, judge whether she could or couldn't decide for herself, but then acted in her best interest by taking the least restrictive option. And in that scenario, it's about saying, actually, although she needs a cannula, it's not so urgent that we need to carry on right now. We have time, we can pull back, and we can try again later. And therefore that's the right balance in that scenario of what's in her best interest.
Restraint is defined as use force or threaten to use force to make someone do something that they are resisting, or restricting a person's freedom of movement whether they are resisting or not. Restraint should only be used as a measure of last resort, after we have considered or tried other alternatives. However, sometimes we need to use restraint in order to deliver care safely and to protect people from potential harm when delivering care and treatment. Usually this will be done with the informed consent of patients themselves. But if a patient is unable to consent, that is to say, they lack the mental capacity to make that decision, then, as we have already discussed, we must act in their best interests. This will include balancing whether or not any restraint is necessary. Examples of restraint in hospital would include locked ward doors, bed rails, mittens, sedation. If you are using any restrictive measure or restraint in a patient's best interests, then you must be able to demonstrate that the restraint measure you are using is in the patient's best interests, is necessary to protect from harm, is the least restrictive effective method, is proportionate to the likelihood of harm, is proportionate to the seriousness of harm. There are lots of instances where restraint is necessary in hospital in order to protect people from harm. Sometimes people are confused about whether what they are doing is restraint and are often not sure whether it can be used or not. It is vital to be aware that restraint should only be used when it is absolutely necessary to protect a person from harm and only after considering other options. However, on some occasions restraint and restrictive interventions will be the right thing to do.
No matter the situation, however urgent, however difficult, we should always be thinking about what's the least restrictive option that's open to us, that would still work, that would still keep the person safe and would still be effective. And there are lots of reasons for that. I mean, the easiest way of describing it is that's a legal principle, we have to do that, we've always had to do that, and we have to demonstrate that we are acting proportionately given the circumstances. And one of those ways we demonstrate that is showing that the action we took is safe and effective, but is the least restrictive of that person's rights or freedom. Sometimes the law is quite clearly telling us not only are you allowed to use restraint, but it's absolutely the right and proper thing to do. But it's based on that straightforward, I think, analysis of where's the balance of harm tipping. Is it so serious, the likelihood and seriousness of harm, that actually we can't delay, we need to use restriction and restraint in order to give her that care that she needs at that point.
You're going to be in for a couple of days. You're going to be because we need to make sure you have full course of antibiotics and things, don't we, eh? Yeah. Oh, you do.
In summary, please remember the following. Patients should always be at the heart of decision-making about their care and treatment. If patients need support or help to make their own decisions, we must give it to them. If a patient is unable to make a decision, then we still include them and talk to other people who know them, and always make balanced judgments in their best interests. Our actions and records must show that we are doing these basic but fundamental things. Making the Mental Capacity Act an integral part of our work improves the protection we give ourselves and our patients, and improves people's experience of the care services we deliver.
It is there to protect the patients, and we aren't Big Brother, we aren't the NHS that decides what will happen to patients. The patients should be very much part of the process, and we should take into consideration different needs of patients. And just because somebody has some issues around capacity, their thoughts, what they would like to have done to them should always be taken into consideration, and we should always listen to their significant others and listen to what the patient would have liked previously before we make decisions about their care.